السلام ورحمة
Can you hear me well now?
Yes.
الله. Yes. Hi, how are you?
Yes.
Hassan, how are you?
الحمد لله.
I'm gonna share the screen just to make sure we can go over the.
السلام عليكم.
Alaikum Assalam wa rahmatullah.
Assalamu alaikum, hi everyone.
Hello.
وعليكم السلام ورحمة الله.
So, Assalamu alaikum everyone and marhaba bikum. Today we're gonna talk over some topics. So the moderator will be Dr. Hassan. When you are ready, Dr. Hassan, go ahead.
So Dr. I can be the moderator today because Dr. Hassan Iftar is gonna be like.
Yeah, sure. Go ahead. So please.
All right, guys. Good afternoon, good evening, good night, everyone. So today the green team is going to present some topics, and Dr. Hassan is going to start this topic cardiology, the second part. Dr. Hassan, are you ready?
So other topics, we will go over some of the journal that you can publish at, but they may be not worthy. Dr. Slaha will present this. We will talk also about Parkinson's disease. Dr. Malas will present this. And then we will touch base on some of the activity regarding the research project. Thank you so much, Dr. Mohammed. And if Dr. Hassan is available, we can start. If not, maybe Sulafa, you can start, and then he can do the second part as cardiology.
Thank you. Are you able to see my screen?
Yes, actually, no.
Sorry. I think just my connection today is a little bit bad. But I'll do my best. If I'm not able to be successful, then maybe Dr. Slafi, you can proceed.
So while Dr. Hassan is uploading his presentation, or I can, if it's the same slides, I can present them or upload them from here, Dr. Hassan. But,
Yeah.
If you work on them, did you work on the slides or it's the same file?
I tried just to update some of the information related to the VTE and those sort of things, but I'm afraid I'm not able to share it. I believe just the connection is a little bit bad here at the hospital.
So while we are working on the technical issue here, I'm gonna just tell you, for those who are joining us today and those who are not with us, we are welcoming every one of you to continue with us for next year. If you want to stay with us, if you want to continue doing your other activities, let's say you want to join a different fellowship, you want to do other activities, we will finish this year. I need you to verify your full name so that we will present the print the certificate. I think most of you, if not all, completed the requirement, which is one research project at least. For those who continue with us, we can continue with the activities as usual. We will ask you to contribute projects. I understand some of you might have some other assignment or obligations. Let's say some of you might want to do step 3. know that you are not available in this period of time because of graduation or other obligation. But I want from you to confirm either you're gonna continue or you're gonna year, which is June, end of June of this year. So thank you.
Thank you, Dr.
And
Nader.
Okay. Okay. Yeah, you are able to share. Yeah, we can see your screen, Dr. Hassan.
Lovely. So I'm going to stop the video, guys, just because the connection is a little bit bad here, and please let me know if there is any issue. So I believe the first part has been presented by Dr. Nader, which is way, way more important than the topics I'm going to go through today. Today I'm going to speak about the valvular disease, about arrhythmia, and finally I'm going to give a brief touch over the VTE. So as for sure here we are talking about the cardiovascular problem in light of the geriatric population. So let me start quickly off without further ado with the aortic stenosis and aortic rigor. By far, this is the most common valvular disease, maybe acute or chronic incidence of both increase with age, rarely severe enough to require surgical intervention. If we move to the mitral problem, mitral stenosis and mitral rigor, less common, present in up to 1/3 of all the adults, but only a small proportion require, even way smaller than the aortic problem. The diagnosis of valvular disease, at the moment we are speaking about echo become like the master of the diagnosis of most of the valvular problem. Echocardiography can assess the cause, the severity of acute and chronic mitral rigor, for example. Also provide important information about left ventricular size, function, and atrial pulmonary pressure. So it's simply echo will give you all of the information you are looking for. And even if you are, for example, concerned about infective endocarditis, again, echo will be the tool of investigation. So when it comes to the clinical manifestation, symptom-wise, regarding the aortic stenosis, it will start by decrease the input to the heart muscle. So the patient might present it with angina, also dyspnea during exertion. Syncope and pre-syncope might be a feature of the aortic stenosis, and not to forget the heart failure. The typical finding in the aortic stenosis, at least in the literature and the medical books, will be the ejection systolic murmur. And as for one of those manifestations, left ventricular hiatus is also one of these things. If you did an ECG for the patient with the aortic stenosis, you might notice the left ventricular hypertrophy, especially in the late stages. No medical problem. If we are speaking about the treatment, the management, medical therapy is usually not effective. Surgical is indicated for certain group of disease. For certain group of patients. Here we are talking about patients with a severe stage of the disease. Aortic regurgitation, not far from the aortic stenosis. However, here, usually the patient will be asymptomatic, but in certain groups, the person might develop dyspnea on exertion, again, angina, and maybe heart failure. On the physical examination, you might find this the feature of hyperdynamic circulation, so increase the pulse pressure, a bounding or collapsing pulse, early diastolic murmur, or they call it decrescendo murmur, and maybe systolic ejection murmur. This is the typical murmur of the aortic stenosis, but it might happen with the aortic rigor. ECG, you might find a feature again of left ventricular hypertrophy. Regarding the treatment, medical less severe cases, again, to control the hypertension and other risk factor, vasodilator like nifedipine, hydralazine, ACE inhibitor as an alternative to the kind of valvular replacement. But of course, if there is no benefit regarding the medical, the surgical is still an option. Mitralis stenosis, this is usually had an association with a rheumatic disease, rheumatic fever, but still it might be have some kind of age-related issue. That's why it's less common than the aortic problem. So gradually worsening, dyspnea on exertion, early orthopnea, and sometimes leg edema. If the condition got worse, the person might decrease or might has a decreased ability or capacity to exercise. On the physical examination, again, the most famous, I would say, murmur, the rumbling with the systolic murmur. The person also might develop pulmonary hypertension. Here, the medical treatment of more important, so we can give the patient diuretic, beta blocker, and those sort of medication. If no improvement, then still there is a chance for a surgical intervention. It's not that common at the aortic issue, but there is a place for the balloon valvoplasty. That's one of the reasons, one of the interventions, sorry. And sometimes we intervene more intensely, so the person might have more kind of valve replacement and those modalities. Mitral regurgitation symptom can be acute or chronic, marked shortness of breath, orthopnea in acute, and mitral rigor in acute severe mitral rigor. Keep in your mind, mitral rigor might happen as a result of myocardial infarction. So at any point, if you are worried about the I'm not sure, do I have any problem with the presentation?
Just we can see the first slide, Dr. Hassan.
Ah, sorry.
Yeah, sorry.
So should I send it to? I believe there is just. Should I send it to you, Sulafa, or to anyone else?
Yes, please. I can share the screen.
Okay. Sulafa, if you don't mind, maybe you can proceed because.
You sent in the chat or in the email? I can put also my email in the chat.
Yeah, please.
Maybe Dr. Hassan, if you share it as a PDF file or email it as a PDF, it would go faster than PowerPoint, the loading.
The problem is actually the problem of loading for me today.
Right. Just save it as a PDF and then share it in the chat or email it to Dr. Sulafa. That will go faster, I believe.
Okay. Sorry for that. Sulafa, maybe you can proceed and then maybe I can continue because I think it's bad here. It's really bad regarding the signal.
Okay, I will start.
Yeah.
And whenever you are ready, we can. So, hello everyone. Today I will present Predatory journal. Can you see my screen?
Yes, we do. We do that.
Yes, we do.
Okay.
Yes,
Yeah, so I will talk about the predatory journals, the rise of worthless biomedical science. So the background of this, according to Merriam-Webster's dictionary, the word predatory refers to anything that is inclined or intending to injure or exploit others for personal gain or profit. So this is a general term meaning. And predatory journals have caused havoc in biomedical science, which is under constant threat from a variety of sources. So the article that Dr. Nader published in our website of our fellowship is very useful and helpful to make us understand the background of these predatory journals, and I found great information in this article. I summarized the article in my presentation, but please try to revise this because it will give you an overview about what's happening, and you can avoid publishing in this kind of journals. So the author mentioned it takes advantages of author by asking them to publish for a fee without providing a peer review or editing service. So if you find a journal that asking you for a fee and it tells you that you can publish without peer review, you should just take a moment to think about this because it's not good for your paper. Always it's good if the journal made a peer review for every paper that is published in their website, so people and the lawyer readers can trust your paper and not have you will not publish in a vague website. And this predatory publication promote worthless scientific research that will bound honest researchers and eager readers of legitimate biomedical journals for decades. So as a result of this, researchers from variety of discipline and background should be made aware of predatory publisher and possible strategy to spot them on regular basis. So we should spot those predatory journal. We can just give feedback, rate them very low rating, so reader can know they are fake and they will not rely on their publication. So this is the article I talk about, shared by Dr. Nader. You can, as I said, you can review it. And predatory journal, a result of the open access movement, which began in the early 1990s. So before we read the journal that publish for public, but after 1990s, it starts to have the open access movement. And we take most of our research now from the internet. So this is the background of when this starts actually. The primary goal of this article is to explore the concern of predatory publishing, include approaches and strategies employed by predatory publishers to prey on young, inexperienced academic. Also the drawback or disadvantage of publishing in predatory journals. So the author starts by making introduction, as the most of article. We start by the introduction, and then we go for method analysis and result and conclusion. So he mentions that the most inspiration goal for young researchers and scientists is to publish their studies in scholarly index journal. That's why if we want to make a research, or if we start to do start paper or do a research, we usually try to search it in Google Scholar or PubMed or other scholarly index journal. The internet, which is widely regarded as one of the greatest inventions and advancements in communication and the transfer of digital content around the world, has played significant role in digitization of content and transfer of published research to lawyer readers around the world. So nowadays, very few people will search of hard copy of the paper. Most of us will use digitalization of content, and we transfer this to lawyer reader around the world. So the advancement of biomedical science is dependent on information obtained through the internet by young doctoral researcher, with most information coming from open access research, which is, I will refer through my presentation to this as OA. So, just a moment, please. So how can you tell if journal is predatory? So how you know? How you avoid publish your paper in this type of journal? So it's not always easy to tell the difference between a predatory journal and a legal one. New predatory journals appear online every day. They have limited existence and impossible to track them. So if also like the government or the public health worker or any stakeholder try to track them, they can't, because they usually appear for limited time and they disappear. So the tracking is very difficult for them. Okay. So why the apologize for cannot pronounce this. Why the in 2017 described characteristic of predatory or fraudulent journal communication or innovation. So he said about 11 characteristics. You can read it and try to know if you receive email, if you contact any publisher, to try to go over these characteristics so you can decide if they are scholarly journal or they are predatory one. So the first characteristic, why didn't say typical predatory journal include words like global, international, universal, Asian, American, European. So when you hear this word, you would think that this is the scholar journal. So you may publish your paper with them, but they mention this word to entice young experienced researchers to submit their work for publication. Another characteristic also, typically they cover a wide range of topics and multidisciplinary in nature, attracting experts from various fields. So the journal can say, we are more interested in human. Then you will find them interested in animals, environmental, occupational, and all this kind of research topic. So they are multidisciplinary in nature. When you found these journals, try to avoid them. That means they are fake. Okay, the third characteristic, they are falsely displaying logo of Committee on Publication Ethics, COPE, on their homepage despite not being member of COPE. They would display a false high impact factor, such as Scientific Journal Impact Factor, SGIF, Global Impact Factor, which is GIF, and the Journal Impact Factor. rather than actual clavariate analytic or the universal impact factor, UIF. So just also be aware of all this term so you can avoid. Just excuse me 1 second. Okay, so also they attract new researcher by promising a short and fast review cycle spanning from a day to week in exchange for premium, like often within 1 month. So also we will make sure if we find this kind of publisher just to think and like try to not publish with them. Also, one of the characteristics, so say falsely claiming to index in reputable indexing service such as PubMed, Medellin, Director of Open Access Journal, or Web of Science by imitating the logo and displaying on their website, even though they are not indexed. So try to search and make sure every publisher you want to publish with them is really connected to PubMed or Medline or other scholar journal. Send unsolicited email or bulk spam email for manuscript submission in upcoming issue utilizing general email accounts from free sources like gmail.com or yahoo.com. Invitation to submit papers on a regular basis, along with invitation to speak at conferences, serve as an editor or review for journals. So this attracts many researchers to publish with them, but also this will be fake conferences. An invitation to submit manuscripts for upcoming special issue, especially those outside the scope of journal and publishing of large number of research in that issue. Okay. So one of the characteristics also you can search for and digging on that, like this website, they have lack of information regarding designation and affiliation of editor member due to large number of editor board members from various nations to give the magazine an international look. And the last characteristic, most of the work is done from sophisticated websites with a mirror image of well-known mainstream index publication. So please try to revise this and make sure when you will try to publish a paper, publish it in one of PubMed, Scholar, Google Scholar, or other type of journal. Okay, so how do these journals work? Predatory journals employ a variety of approaches and tactics to establish legitimacy and draw the attention of naive young academics. One such tactic recently exposed under the gloomy umbrella of predatory publishing is predatory conference. And I'm sorry, I referred before to PubMed as journal, but I mean like AMA, MCA, and this kind of journal. So what are the drawbacks of writing for predatory journal? What are the disadvantages to write in this type of journal? So as predatory journals have a weak or non-existent review system, unethical research with false, plagiarized, or manipulated data can enter the larger academic community. So any person, even if not a researcher, can enter vague data, plagiarize, just he will paraphrase or even not be paraphrase, copy paste and put and enter large academic community through this paper, and determining the quality of research that is based on such research and flooding the minds of young and inexperienced researchers with false knowledge who are like, it will flood the readers with many false publications. So this should be avoided. Continuing is on disadvantage of predatory journal, there is also, on the other hand, several shortcomings of publisher in meeting the requirement of scholarly journal standards, such as absent or weak peer review system, lack of reliable archiving system, for scientific articles, so they have very weak archiving system. Failure to disseminate this published work to deserving scientific communities may result in loss of scientific data funds and genuine researcher hard work. So the researcher hard work will publish, will paraphrase just with plagiarism, and they will publish in this kind of journals. So the author conclude this in his article, like he said, this review article will discuss the challenges of predatory publishing and approach strategy employed by predatory publisher to attract young and inexperienced academic. So he mentioned that these predatory publishing challenges necessitate raising awareness among young, inexperienced academic researchers about the potential implication of this predatory publishing practice. Therefore, instead of banning or creating specific laws or committees to investigate this journal, it's proposed that all academic educational institutes focus on providing specially designated courses for postgraduate students, young untrained researchers, and faculty members to raise awareness of predatory publishing and develop new ways to combat it through active discussion with researchers. And this is the reference, the article shared by Dr. Nader. Thank you so much for attending, and please, if you have any question, feel free to unmute yourself or put your question in the chat.
Thank you both, Dr. Hassan and Sulafa, for the great presentations. And
Thank you.
if you have any questions, please go ahead. So I just want to share with you, I got some emails in the past with similar invitations, like they seek to invitation, let's say in Asia, in Japan, or in China. And then they mentioned that this is international and so forth and so forth. So for this, you want to make sure you verify what's going on with these conferences. Are they legit? Do they have previous ones? Are they publishing? Homework, you can find out if they are through conferences or just they are after the money for you to send the prescription of the registration fees, and then they will disappear. And same with journals, you want to make sure they have published in the past, they are indexed in PubMed or Google Scholar, the 11 points that Sulafa was just mentioned. So you don't want to fall in their trap, basically. But that's Sulafa. Anyone else who has questions? Or...
Thank you so much, Dr. Nader, for sharing this.
Yeah.
Okay, thank you all. And right in next meeting, if Dr. Nader agree, we can add this for the next meeting agenda.
We can do that.
Yeah, Dr. Ala want writing article next meeting, steps in writing an article. Okay.
If no other questions, maybe we can go to the next item in the agenda.
Dr. Sulafa, I send it to your email and to the group. If you can share it with me, please.
Sure, Dr. Hassan, I will open it now. I'm sorry, my email is a little bit slow in opening.
It's also in our group.
Sulafa and Hassan, I can go ahead with my presentation until this problem will be solved.
Sure.
Sure.
Okay.
Okay.
Hello, everyone.
Hello.
You can hear me well?
Yes.
My screen is obvious.
Yes.
So today we will talk briefly about the Parkinson's disease. Parkinson's disease is a degeneration in the basal ganglia, which consists of striatum, which is caudate nucleus and putamen nucleus and substantia nigra. What is the main job of basal ganglia? It coordinates and modulates the movement. How this basal ganglia can do this? By initiating it will initiate the movement, and it will initiate the needed movement, and it will stop the unwanted movement. How it will initiate the needed movement? Thalamus will give excitatory neurotransmitters to the cortex, the motor cortex, so it will initiate the movement. How it can control the movement? By inhibiting the unwanted movement. Thalamus will project excitatory neurotransmitters to initiate, and the cortex will send excitatory neurotransmitters to striatum, which will inhibit the globus and substantia nigra, which will lead to inhibition of thalamus, so inhibition of unwanted movement. What's the cardinal motor features for Parkinson's? They are mainly three: bradykinesia, along with tremor, rigidity, and postural change. Tremor, usually resting, while rolling often involve thumbs, and it's usually the starting complaint of a patient with Parkinson's disease. Bradykinesia, slow and small movements, reduced blink, face expressions and gesturing, soft voice, difficulty getting out of chairs, shuffling steps, reduced arm swings, and breathing. Rigidity, which is different from spasticity, postural change, imbalance, falls, stooped, flex, posture. Patient joints will be flexed, like knee and hips will be flexed, and even elbow will be flexed. Differential diagnosis of Parkinson's disease, which can be idiopathic or can be genetically precipitated. Parkinson's with degenerations, it can be caused by Lewy body, which is dementia, along with Parkinson's. Supranuclear palsy, corticospinal degeneration, multiple system atrophy. Also, Parkinson's can be drug-induced, like the use of antidopaminergic, like antiemetics and like this. Rare but treatable in young people can be precipitated by Wilson's disease and dopa-responsive dystonia. Others also, Parkinson's can be precipitated by multiple CVAs, which is vascular Parkinson's, brain tumors, by CNS infections. Drug-induced Parkinsonism, drugs that reduce dopamine transmission, like antipsychotics, antiemetics, risperidone, haloperidol, metoclopramide, promethazine, and etc. can be indistinguished from Parkinson's disease. Clozapine is an antipsychotic, does not seem to cause it, and quetiapine have very low rate of causing drug-induced Parkinsonism. The management of drug-induced Parkinsonism is to reduce or discontinue, if possible, the offending agent, and it can take months to resolve. Parkinson's disease itself, usually idiopathic. It's characterized by degeneration of the nigra, which causes dopamine deficiency in the striatum, which will lead to the manifesting motor symptoms. Dopaminergic therapy usually relieves the motor symptoms. In the normal substantia nigra, it will be well pigmented because there is dopamine. In Parkinson's disease, there will be hypopigmentation due to dopamine deficiency. Parkinson's disease, common early complaints, resting tremor, usually involving the thumb, writing smaller, hard to button. Buttoning will be hard for the patient, slowness, weakness, limb not working well, as the patient described, stiff or achy limb, stoop, shuffle walk, which is dragging legs, trouble getting out of chairs due to rigidity or turning in bed, low or soft voice. Also speech will be affected. Non-motor symptoms will be anosmia, it will affect the smell, dream, hallucination, constipation, anxiety, depression, and passiveness. Medication for motor symptoms. We will try to give the patient dopamine in form of levodopa with carbidopa. Levodopa will be converted in the brain to active form of dopamine, and carbidopa will inhibit the peripheral decarboxylation of dopamine, so it will enter the brain. It's most effective and usually best tolerated by the patients. Dopamine agonist, second line, like pronipirol, pramipixol. Others have only modest benefit, like MAO-B inhibitor, anticholinergics, and amantadine. When we should start medications for patients with Parkinson's disease, we should start early. Drugs are symptomatic, not neuroprotective or neurotoxic. This is very important. Just our aim is to reduce the motor symptoms in the patients, no neuroprotection or neurotoxicity from the medication itself. And what's our goal is to improve the patient functions, which is a best guide if the treatment work well or not. Response to the dopaminergic therapy, especially levodopa, is the best available test for Parkinson's disease. Which treatment to start? As we said, the most effective and most tolerable mode of treatment or medication for Parkinson's patient is levodopa. It will improve the motor symptoms, which is bradykinesia, tremor, and gait changes. A family physician can start the levodopa. Dopamine agonists cause more non-motor side effects and are best avoided in patients above 70. For dopamine agonist should be avoided in older patients more than 70 because it will precipitate to non-motor side effects like autonomic or urinary symptoms. Delaying levodopa is of no benefit in long term, so it should be started early. Treat more for symptoms and function and less for how the patient looks. Okay, our aim is to improve the function of the patient, nothing else. Allow adequate dose and time to work before concluding failure or not PD. If we increase the dose, we will give the patient time to see if there is response or there is failure of response. Resting tremor may be medication refractory in some patients and does not conclude not Parkinson's disease. Tremor, even with medications, can be refractory. Levodopa is the most effective overall for motor symptoms. A fine option for initial therapy for Parkinson's disease, as we mentioned, by mid to late disease is almost always needed. Non-motor side effects include nausea, orthostasis, sleepiness, hallucinations, but not as much as other Parkinson's disease drugs like dopaminergic agonist and monoamine oxidase inhibitors and like this. Motor side effect of levodopa is dyskinesis, and it will, the side effect will increase with period and dose. Carbidopa, levodopa dosing, commonest preparation is regular 25 to 100 mg. We can start with 1 pill BO TID to 1.5 TID to 2 pill TID with meals to reduce the nausea. 2 weeks between steps to appreciate the effect. If we increase the dose, we need to wait at least 2 weeks to see if there is a response or not. If there is no response, when we will say there is no response, if we increase the dose to at least 900 mg per day, we can say there is no response for treatment. Some patients can need QID or more frequent dosing, even Q3 hours in advanced disease. Typical dose for levodopa ranging from 300 mg, which is 100 TID, or up to 1500 mg. The second treatment line is dopamine agonists. Can be used as monotherapy in early disease, and we can use with levodopa in mid to late disease. Can add to levodopa to reduce off time. Frequent side effect is nausea, sleep attacks, hypotension, compulsive behaviors, and edema. More prone than levodopa to cause hallucinations and confusion. So it should be used cautiously in older patients. In mid to late Parkinson's disease, patient will have more motor complication, including dyskinesis and on-off fluctuations. What's on-off fluctuations? Parkinson's patient with the use of medication will have periods of good response to therapy, so they can move well, and medication will work well. Then they will have relapse and the movement will be severely affected. Then we'll jump to good movement. Then we'll jump to bad movement. More drugs-resistant motor symptoms, impaired balance with falls. This is in mid to late Parkinson's disease. They will be prone to more non-motor symptoms, especially dementia and hallucination. In mid to late Parkinson's disease, also you will need more medication, so more side effect. Managing this complexity in mid to late Parkinson's disease requires great experience. Motor complications as Parkinson's disease progresses, fluctuation, medication wear off before next dose of periods worse as disease progress. Okay, patient response to treatment, and no response for treatment for longer period. This period will be told than the usual as the disease progress. Dyskinesis usually at the peak of on period. In this stage also, we will need large and more frequent medication dose or combinations of drugs to control these motor complications. Also, last line, we can go for surgery, which is deep brain stimulation option for some patients with medically refractory motor complications. So if the motor symptoms not controlled with levodopa or combination therapy, we increase the dose and still no response, we can go for deep brain stimulation. Some motor symptoms may not respond to medication adjustment. Even if we increase the dose, if we adjust the dose multiple times, there will be no response, like postural instability and falls, like gait breathing, fatigue, dysarthria, dysphagia, and some tremors will be refractory to the treatment. We talked about the motor symptoms and treatment and complications. We will talk about non-motor symptoms, which is psychiatric. Patient can present with symptoms of depression or anxiety. Autonomic, blood pressure, mostly hypotension, genitourinary, mostly urgency, and in rare cases incontinence, and GI like constipation. Sleep, the REM behavior disorder, insomnia, hypersomnia, sleep apnea. Also, patient can manifest fatigue and cognitive impairment like psychosis and dementia later on. Why there is no non-motor symptoms, in spite that the basal ganglia control the motor part of the motor cortex, initiation and inhibition of movement. Parkinson's disease affects many parts of the nervous system. Earliest involvement in gut nervous plexus, lower brainstem, and olfactory bulb. Pathology move up the brainstem, also serotonergic, noradrenergic, and cholinergic nuclei. So at the start, it might affect just the dopaminergic neurons. Later on, it can affect even serotonergic, noradrenergic, and cholinergic nuclei. Non-motor symptoms, examples, anosmia, constipations, and other often predate motor symptoms. Psychiatric manifestations of Parkinson's disease can present in form of depression and anxiety. It's not just because the patient in a lot of stress because of diagnosis, it may be part of the illness itself. Motor symptoms and wearing off can interact with mood and anxiety levels, can misinterpreted by poker face as depression. These Parkinson's people will have mask face, can be misinterpreted as depression. So we should assess for depression in a well manner. SSRIs can work, but we should avoid benzodiazepines because benzodiazepines have a lot of side effects in older adults. We should consider support services. Parkinson's patient with depression or anxiety with psychiatric manifestation need psychotherapy for the patient and even for the caregiver. Geriatric psychiatrists usually have better expertise in this population. We have also autonomic symptoms. This is one manifestation of the non-motor symptoms. Blood pressure dysregulation causes orthostatic hypotension and supine hypertension. Patient may have syncope, and it can be complicated by injuries. These autonomic dysfunction will be worse with dopamine agonist and with higher dose of L-DOPA. Lower extremity edema may also reflect vascular dysregulation. So Parkinson's patient can come with hypotension and supine hypertension. Recognizing orthostatic hypotension, not all have the classic light-headed feeling. Others cause abrupt falls, weakness, buckling, or shaking of legs or body, being dazed, confused, coat hanger ache, which is neck and shoulders ache. How we can manage orthostasis in Parkinson's patients? First step, we should reduce or stop antihypertensive, which may precipitate orthostasis, like diuretics and other offenders, including some Parkinson's disease medications. Don't overtreat, isolate high blood pressure. 3 minutes orthostatic blood pressure give a clearer picture. Water, salt, water, salt, and water. So it should be managed by increasing water and salt intake. Elevate head of bed to 30 degrees. Compression stockings. Teach first aid if the patient have sudden orthostasis, syncope, or any accident. How we can manage orthostasis through medications? By fludrocortisone, which will retain body sodium, and we should be aware of the side effect of hypokalemia, midodrine, which raises blood pressure, and we should be aware of the side effect of supine hypertension, droxidopa, turn to norepinephrine, which will raise the blood pressure. Also, we should be aware of the side effect of supine hypertension. Urinary symptoms in form of urgency, frequency, nocturia are very common in Parkinson's disease. Obstruction and retention are less common. Incontinence is uncommon early on. Pathophysiology can be complex in any given patient. Confounders are age, These urinary symptoms can be caused by aging or prostatic disease or other motor problems. Managing urinary symptoms. How we can manage the urinary symptoms? Through non-pharmacological time voids, head of bed up for nocturia, bladder antispasmodic like oxybutyl, mirabegron, and consider urology referral if there is urinary symptoms refractory to this treatment. Constipation in Parkinson's disease may predate also motor symptoms by years. It will start slow transient or outlet obstruction. Step 1, dietary modifications. We should increase the fiber and water content in the diet. Step 2, we can start also with mild osmotic laxative like polyethylene glycol. For patients not responding to conservative measures, we can consider specialty referral. Also, Parkinson's have sleep complications, REM sleep behavior disorders, typically in men, often years before motor symptoms even, complex movement or frightening, usually early in morning, varying frequency, patient's or bed partner injury. He can have REM sleep disorder, which will lead to patient or partner injury. The treatment of this REM sleep behavior, we should treat any underlying cause like obstructive sleep apnea. We should make the sleep environment safer to prevent any injuries. We can give melatonin 3 to 12 mg QHS to help mild to moderate symptoms. Clonazepam 0.25 to 1 mg QHS may be needed for more severe symptoms. So we should start with determining if there is any combined comorbidity which will cause this sleep disorder, and we should make the environment safe. We can go to melatonin and clonazepam. Reserve for the severe symptoms. Obstructive sleep apnea. We should maintain high level of suspicious. Can present with snoring, daytime somnolence, nighttime awaking, nocturia, worsening dreams. Insomnia can be primary or secondary. We should address first the patient's sleep hygiene. We should review also the medication list. Can be side effect of medication. We should treat nighttime motor symptoms because it can be the cause of insomnia. We should think always of obstructive sleep apnea. And we should treat any psychiatric comorbidities. Then we can go to sedative or hypnotic, as we said, melatonin and mirtazapine and clonazepam. Also, patients of Parkinson's can come with hypersomnia, which is increased sleep need for many patients. It may be due to poor sleep at night because of motor symptoms or because of any other comorbidity like obstructive sleep apnea. We should start first by reviewing the medication, especially dopamine agonist, anticholinergics, benzodiazepines, and other sedatives. Fatigue. Patient of Parkinson can become also with fatigue, tired, weeped out, no energy. Is it sleepiness or wearing off or motor or mood? Why he's fatigued? We should figure out the cause of fatigue. Isolated fatigue can be disabling. No established treatment, though antidepressant and stimulant have been tried. Encourage light exercises, hobbies. We badly need better treatment for this. Hallucinations and dementia in Parkinson's disease complicate many long-standing Parkinson's disease. This may be late in the disease. Hallucinations are usually visual. Main contributor are disease progression, brain pathological change, age, and medications. Older patients much more at risk. Marker of increased morbidity, mortality, and institutionalizations. So hallucination and dementia means this is advanced Parkinson's disease and there is high morbidity and mortality in this case. In hallucination and dementia, we should always rule out the medical causes like B12 deficiency and thyroid problems. And we should simplify medication regimen. We should prioritizing eliminating anticholinergics, cholinergics agent and dopaminergic agent agonist and reduce the levodopa loss. We will start with modifying the treatment, eliminate the anticholinergic and dopamine agonist, and we should reserve reduction of is FDA approved in Parkinson's dementia. Antipsychotic off-label black box warning, quetiapine and clozapine, as we said, least likely to worsen Parkinson's symptoms. Thank you.
Thank you so much, Dr. Mitralis. This is also a great presentation and concise to the point. And great. I appreciate your input and thank you for great presentation. Any questions? Any comments?
Yes.
I think Dr. Muhammad Ibrahim, go ahead, has a comment.
So if no one have questions, I have question for you. A small question: how we diagnose Parkinson's disease? We did not came across this point in the presentation. When we can say this patient have Parkinson's disease? Do we have image? Should we depend on the clinical scenario?
Yeah, I think mainly clinical. So presence of
yes,
fine resting tremors and bradykinesia, and doing the imaging and other investigations to exclude the other causes. But for the Parkinson disease, to my knowledge, mainly clinical. You can diagnose this clinically.
Yes, you're right. There is main three symptoms, which is rigidity and tremor and dyskinesia. We should depend on these factors. 2 out of these 3, we can conclude this patient have Parkinson's. Also, image can, like SPECT scan and like this, can help, but the diagnosis is mainly clinical.
Comment, go ahead, Lina. Also, Dr. Muhammad Ibrahim mentioned that L-DOPA has on and off phenomena. Thank you. Thank you all.
Lina, I guess you are muted.
Actually, I want to answer the question, but Dr. Muhammad just said what I want to say. Mainly clinical.
Thank you so much.
Nice presentation, but I think.
Thank you. Thank you.
Once again, thank you, Dr. Mitralis. Thank you, everyone. And we can go to Dr. Hassan. Sulafa, are you ready with the presentation slide?
Yes, I can share the slide now.
Yes.
Okay.
I have just one question, Dr.
Yes,
I'm
please.
sorry.
Go ahead, Dr. Mitralis.
Who should treat Parkinson's?
What's that?
who should treat and monitor the treatment like this in Parkinson's disease? Geriatric physician? Yes. Who is responsible for this long journey, increasing the medication, decreasing?
Yeah, so in geriatric, always we work as a team. So, and the specialist, let's say neurologist, or will titrate, but the family doctor will continue and adjust as needed. In our practice, I go to nursing home, so I work as a primary care for my patients. So but I work in teamwork with the neurologist. So if they follow up and they want to adjust, increase the dose, for example, I can agree with that or disagree depending on what my report or information I have. Sometimes the patient may have some side effects. Let's say they have hallucination, and this is disturbing their life quality or quality of life. So if they don't mention that to the neurologist, and if the neurologist or specialist wants to make adjustment, we can discuss, or I can override their recommendations. So basically, we work in a team format. There is no one clear, like I'm the boss, I will treat this by myself or something like that. Thank you.
Thank you. Also, I want to mention just one point. We should not forget to let Parkinson's disease to eat well, to hydrate well, and to be engaged in their loved hobbies, because it's stressful disease. So they should have great support and good lifestyle.
Excellent, yes. And try as much to prevent falls and risk to the patient. So, yeah.
Thank you.
So when Dr. Hassan and Samantha are ready, we can go to the other part.
So I will be presenting on behalf of Dr. Hassan because he has a problem with connection.
Go ahead. Thank you.
Okay.
Do you have the slide, Dr. Muhammad, or I will share?
Yeah, share it. I don't have any slides.
Okay, yeah. Can you see my screen?
Yeah, just make
Okay.
it. Click on the slideshow.
Yes. I'm sorry, just I will.
You did not share, Sulafa.
I didn't share. You cannot see my screen.
Yes, or maybe for me.
I see it.
We can see it. We can see it. Maybe.
Okay.
Just slideshow. Sorry.
And go back to arrhythmias.
I'm sorry. What number?
10.
10. Okay. Okay.
All right. Hi, everyone. Okay, I'm going to continue on Dr. Hassan presentations. He completed valvular disease. I'm going to continue the cardiac arrhythmias. So the cardiac arrhythmias is age-related change in the cardiac conduction system coupled with the increasing prevalence of cardiovascular diseases at older age, and leading to progressive increase in the incidence and prevalence of conduction abnormalities and heart rhythm disturbances in older adults. So as we know that with old age, there is some changes in the autonomic nervous system and decrease the response of the receptors with moving, like having orthostatic hypotensions and postural hypotensions due to decreased reflexes from the carotid sinuses and the carotid bodies. And also the age-related degenerative changes in and around the sinoatrial and atrioventricular nodes lead to an increase in the bradyarrhythmias with advancing age. So mainly degeneration and fibrosis of these nodes lead to desensitizations. The most common sustained arrhythmia seen in the atrial fibrillation is the most common sustained arrhythmia seen in clinical practice. And the incidence and prevalence increase exponentially with age, such that the prevalence is octogenarians. That means that the patients are in 80s is approximately 10%. Among older patients with valvular heart disease or heart failure, the prevalence is even higher, approaching 30%. And we know that also the hyperthyroidism, one of the causes of the atrial fibrillation. Next. The clinical presentations of the atrial fibrillation, having symptoms related to atrial fibrillation are highly variable. The most common palpitations, shortness of breath, or impaired exercise tolerance. Some patients are entirely asymptomatic, and according to my experience, most of the patients that I have seen in the cardiology clinic here are, especially the young patients, are asymptomatic, just discovered incidentally with doing the EKG or for workup for other problems. Others present with acute pulmonary edema. That means they develop heart failure. In patients with ongoing atrial fibrillation, the standard 12-lead EKG is diagnostic. So the lab studies should include echocardiogram, serum electrolytes, especially the potassium and magnesium, and thyroid function. So mainly by the EKG. Okay, objectives. The management of the atrial fibrillations, we are aiming to relieve symptoms and to minimize the risk of thromboembolic events, particularly stroke, which is most common complications of untreated atrial fibrillation. So the principal strategy for relieving symptoms is control of heart rate and maintenance of normal sinus rhythm. So as we know that we have the two kinds of treatments for arrhythmias, is rate control and rhythm control. But the most commonly used treatment for atrial fib is rate control with beta blockers or calcium channel blockers. And patients who experience significant shortness of breath, fatigue, or exercise intolerance attributable to atrial fibrillation may be best managed with anti-arrhythmic drug therapy aimed at maintaining sinus rhythm. Now, alternatives to anti-arrhythmic drug therapy for maintenance of sinus rhythm include catheter ablation of the arrhythmogenic foci, usually through pulmonary vein isolation and the surgical maze procedure. So we have medical treatment and interventional treatment. All other older patients with paroxysmal or persistent atrial fibrillation require stroke prophylaxis. Two main options are warfarin titrated to maintain an INR of 2 to 3 and aspirin 75. The small dose, we call it as baby aspirin 75, 81, or the higher dose is 325 milligram per day, alone or at times in combination with clopidogrel. So in the clinic I'm working now, the cardiologist, so the warfarin is rarely used. Now they use the factor 10 inhibitors like Xarelto, is called rivaroxaban, and apixaban, also called Inquis. Because they do not need any kind of monitoring and with less side effects than the warfarin. It is helpful to stratify atrial fibrillation patients according to stroke risk. We use a CHADS2 scoring. It's currently the most widely used scheme. So I think every one of us here has taken step 2 exam or step 3. So this is scoring system is common and should be memorized by heart. Okay. The CHADS2 or CHADS2 assigns 1 point for chronic heart failure, hypertension, age more than 72. No, the age for 72 years or more should be having 2 points. And the diabetes, 1 point, and 2 points for prior stroke or transient ischemic attack. Okay, in general, patients with CHADS2 score 0 and sometimes even with 1 are at low risk of a stroke, and the risk of warfarin outweighs the benefits. The benefit aspirin surveys above it. Also, it's in other places mentioned that people with 0 score, they shouldn't receive anything. Or maybe they can receive aspirin. It depends on the treating physician. But people having score 1, you can use either aspirin or an anticoagulant, any anticoagulant. And or those with 2 score or more, they are absolutely has to have an anticoagulant, warfarin or any other anticoagulant. And according also to my knowledge that the warfarin only used in patients with having valvular diseases on the top of atrial fibrillation. Other supraventricular arrhythmias, like atrial flutter, usually occurs in older patients with concomitant atrial fibrillation, and management is similar to atrial fibrillation. Symptomatic persistent atrial flutter and unsatisfactory response to medical therapy. With those kind of patients, we should consider catheter ablation. The other supraventricular arrhythmias, like atrial tachycardia, AV nodal reentrant tachycardia, accessory pathway mediated supraventricular tachycardia, and multifocal atrial tachycardia. It should be treated, should be managed by treating the underlying condition, provide rate control medications. In selected patients with recurrent symptomatic episodes, anti-arrhythmic medications or catheter ablations may be considered. Next. Frequent ventricular premature beats, ventricular couplets, and short runs of non-sustained ventricular tachycardia, no therapy, and less highly symptomatic, in which case beta blockers are the medications of first choice. Longer episodes of ventricular tachycardia associated with dizziness or syncope, treated by referring the patient to a cardiologist or electrophysiologist for implanted cardioverter defibrillator or anti-arrhythmic drug therapy. In patients with New York Heart Association class 2 or 3 heart failure, left ventricular ejection fraction of 35% and or less, and life expectancy 1 year or more, the patients may be considered for an ICD regardless of whether ventricular arrhythmias are clinically manifest. Next. Now we are going to discuss bradyarrhythmias. To finish the tachyarrhythmias, bradyarrhythmias, patients with mild bradycardia, that means resting heartbeat 50 to 60 per minute, are often, those kind of patients are often asymptomatic. And by the way, I am one of those patients. My heart rate ranging from 58 to 70. So may protect against development of angina pectoris in coronary artery disease patients. So we don't need taking any beta blockers. Patients with more marked bradycardia, that means the resting heartbeat less than 50, 40 to 50, maybe experience fatigue, lightheadedness, especially on standing, or reduced exercise tolerance. Pre-syncope or syncope may occur in patients with profound bradycardia with the heart rate less than 40 beat per minute or asystolic pulses 3 or more seconds. Whether due to sinus node dysfunction or heart block within the AV node or infranodal conduction system. Next. So, a diagnosis of bradyarrhythmia started by excluding significant electrolyte abnormalities, measuring the thyrotropin level to exclude hypothyroidism, and reviewing the patient's medications. So the medication is most implicated in bradyarrhythmias and tachyarrhythmias. Detection of significant orthostatic hypotension should prompt a search for potentially treatable causes, including adverse effects of medications, dehydrations, or autonomic dysfunction. For example, due to diabetes, myelinosis, Parkinsonism, or other neurological disorder. Patients with pre-syncope or syncope should undergo carotid sinus massage to evaluate for carotid hypersensitivity. But we should be careful to doing the carotid sinus massage because we could dislodge any atheroma and may cause an embolic phenomena with a stroke. Okay. If symptoms occur daily or almost every day, like a 24-hour, 48-hour ambulatory monitoring may be helpful for confirming or excluding bradycardia. Yes, well, the most commonly used is the Holter monitor, used for 24-hour, 48 hours, 72 hours. And if there is no symptoms, you can extend it up to 1 month, just to have a big background of the heart rate and the rhythm. So the monitoring may be helpful for confirming or excluding bradycardia or the other heart disorder as the proximate cause. In patients whose symptoms occur at least once a month, but not daily, a 30-day event monitor may provide definitive diagnosis, as I mentioned. In patients with rare, less than monthly, but recurrent symptoms of serious nature, like syncope with injury, an implantable loop recorder may be considered. Next, okay. For the management, confirmation of the management, correct any treatable causes. like hypothyroidism, so we can call it modifiable causes, and eliminate potentially offending medications if possible. In patients with confirmed symptomatic bradycardia, not amenable to conservative management, they need permanent pacemaker implantation to control their bradyarrhythmia. Next. That's it. Now we finish the arrhythmias. The coming topic is peripheral arterial disease. Well, the peripheral arterial disease encompasses disorders of the abdominal aorta, renal and mesenteric arteries, iliofemoral popliteal artery, arterial tree. Prevalence increases with age and is higher in men than in women. Risk factors include hypertension, diabetes, cigarette smoking, which is one of the highest risk factor for peripheral arterial disease, and family history. Next. So for the diagnosis of the PDA, at least 50% of the patients with PDA are asymptomatic or attribute their symptom to another disorder. This proportion is probably even higher in older adults due to more sedentary lifestyle. Formal history and physical exam to screen for symptoms and signs of PDA is recommended. Because the mainly presenting symptoms is leg claudications with exercise or with movement. So patients 50 to 69 year with risk factors for atherosclerosis. Formal history and physical exam to screen for symptoms and sign of PDA is recommended for patients from 50 to 69 year old with risk factors for atherosclerosis. Patients 70%, 70 years old or more with or without risk factors. Men 60 years old or older with a family history of abdominal aortic aneurysm. So the treatment for the PAD, so mainly with modifying the modifiable risk factors like smoking, cutting smoking or quitting smoking, and controlling diabetes and hypertension, exercise, and also the medications. So taking the aspirin, 75 to up to 325 milligram. Clopidogrel, 75 milligram is more effective than aspirin in reducing cardiovascular risk in patients with PAD, but aspirin plus clopidogrel is not superior to either agent alone. So it's better to use one of them, and clopidogrel is more effective than aspirin. Clopidogrel is recommended as a reasonable alternative to aspirin in selected patients. Okay. And an ACE inhibitor or ARB for prevention of cardiovascular events. So the treatment of the BAD is the same like the myocardial infections. It's taking the blood thinners like aspirin, clopidogrel, and taking the lipid lowering agents like statins. This is the main part of the treatment. The ACE inhibitor or ARB for prevention of cardiovascular events is reasonable in patients with symptomatic peripheral arterial disease. Patients with leg peripheral arterial disease should exercise regularly, preferably under supervision. They call it supervised graded exercise to include walking at least 30 to 45 minutes at least 3 times a week for a minimum of 12 weeks. Next. So if the medical treatments fail to control the symptoms of the BAD, then revascularization is indicated for patients with severe symptoms attributable to BAD that have not responded to aggressive risk factor modifications, exercise, and pharmacotherapy. Revascularization is also indicated for patients with critical limit ischemia, defined as rest pain, ulceration, or gangrene. In this context, revascularization has been shown not only to improve symptoms, but also to reduce the likelihood of subsequent amputation. It's like we call it life-threatening limb. They should be treated by revascularization, either erient or emergent. Next. The next topic is Vena thromboembolic disease, mainly with DVT and the BE. Symptoms and signs similar in older and young patients. Most patients with DVT and or pulmonary embolism are asymptomatic, maintain a high index of suspicion for these conditions, particularly in hospitalized patients and in residents of transitional care facilities and nursing homes. As I heard from my friend who is doing residency, said that it's been very common in the admitted patients, the PE. So any patients is admitted to the hospital develop sudden chest pain, hypotension, shortness of breath, the PE should be excluded. The utility of most routine tests for diagnosing venous thromboembolism disease include blood tests, arterial blood gases, chest radiograph, and ECG is quite low. Normal test does not exclude a diagnosis of DVT or PE. So the thromboembolic disease prophylaxis with low molecular weight heparin or fondaparinux is preferred over unfractionated heparin. Hospitalized older adults who are not fully ambulatory, so those people who need prophylaxis with low molecular weight heparin. The hospitalized older adults, not fully ambulatory, residents of transitional care facilities and nursing homes at increased risk of disease because of disability, immobilization, or chronic medical conditions. According to the modified Wells criteria. Okay, the treatment for the venous thromboembolic disease, as general principle, oral agents are typically preferable to parenteral agents. For most non-pregnant patients who do not have severe renal insufficiency or active cancer, we suggest the direct inhibitors, rivaroxaban, which is like commercially, or the brand name is called Xarelto, apixaban, called Eliquis, indoxaban, or dabigatran, dabigatran is direct factor 2 inhibitor. And the rivaroxaban and apixaban is factor 10, activated factor 10 inhibitor. These medications preferred rather than the warfarin, and the warfarin should be suggested more than the low molecular weight heparin. So to summarize, aging is associated with extensive change throughout the cardiovascular system that lead to progressive decline in cardiovascular reserve capacity, substantive alterations in the clinical presentation, response to therapy, and prognosis of cardiovascular disease. Older adults account for the majority of patients hospitalized with acute coronary syndrome, and more than 80% of death attributable to acute coronary syndrome occur in patients 65 years or older. Older patients are at increased risk of major complications from therapeutic interventions for acute coronary syndrome. Atrial Fib, the most common sustained dysrhythmia in clinical practice, increases in prevalence with age, and 50% of all patients with AFib are age 75 years or older. Most older patients with AFib respond to rate control medications, plus or minus anti-thrombotic therapy, but some require anti-arrhythmic drug therapy to maintain sinus rhythm and alleviate symptoms. The prevalence of PAD increases progressively with age, and PAD is a potent risk marker for concomitant coronary artery disease and cerebrovascular disease. Management of PAD should include appropriate treatment of hypertension, dyslipidemia, diabetes, and on top of that, the smoking cessation in accordance with existing practice guidelines. Next. So now the time for the problems.
I think we can skip them, the
Okay.
problems, we can skip them. But
All right.
thank you so much, Dr.
You're welcome, Dr. Nadir. So anyone has any questions? Can answer.
If there is any
I'll be
question,
able to answer, then Dr. Hassan or Dr. Nadir can jump to answer. Okay.
I have a question.
Yeah, go ahead.
For peripheral artery disease, should we use ACE inhibitor routinely, or just if there is another risk factors for cardiovascular disease, or peripheral artery disease considered as cardiovascular risk alone, we should start ACE inhibitor? Because here we are not using, so it's new for me.
Yeah, also
So
according
is it
to,
routine?
no, according to my knowledge too, it's not like a routine using ACE inhibitors with people with PAD, but PAD most commonly in patients with already having cardiovascular disease.
Other risk factors.
Yeah, coronary artery disease or diabetes. But the main treatment, medical treatment, is the blood thinners, the lipid lowering agents, and exercise. And in addition to modifying the risk factors, especially the smoking cessation.
Smoking.
Yeah.
Thank you.
You're welcome.
thank you again, Dr. Mohammed Ibrahim. Great presentation and to the point. Thank you. Jumping in spot for Dr. Hassan. All right. Any other questions? Thanks, Mark, for the great question. Any other questions or any other comments regarding this topic? I'm going to just share with you two cases. I think one of them is about PE. And so in older adults, some might present atypically, like usually with PE, people will develop the DVT and then it will go to their lungs and then they present with shortness of breath, heart rate might be fast. So these are the most common presentation for them, shortness of breath, and when you check the oxygen might be dropped. in older adults, and they may come up with just change in condition, change in mental status. They were able to walk around. Now they are bedridden. When you ask them, they feel tired, just they don't know what's going on. And I had a case like that when we try to figure out, usually blame the medication. So we looked at the medication, nothing new, nothing causes symptoms. We checked the urine and the X-ray, all are negative. So we excluded infection. So she started to develop some shortness of breath after she had the initial symptoms with just change in meditation. She's up and down, and she's awake and sometimes sleep. So we sent her to the hospital and they did the CT for the PE and it was positive. So sometimes you think about that. One more note is using the D-dimer. Sometimes you can check that with the lab test. If it's negative, it's helping that you can rule out the DVT or the PE. But if it's positive, it indicates there is a possibility. So you need to do the other investigation as far as ultrasound for DVT or CT scan to rule out the PE or others test. Thank you.
And also, I remember to add, also for the BAD, we use ankle brachial index for the diagnosis. Yeah, the normal is between 0.9 to 1.3. Less than that is considered diagnostic. More than that is usually with elderly people, increase the rigidity of the basal wall.
So thank you so much. Thank you for the comment. Okay. Anybody else? Any questions? Any comments? If none, we can go to the next. So next agenda. Thank you everyone for the presentations and your effort. Good job. So talking about the new projects, ideas, and the future. So we've been accepting applications, and we interviewed some of the new fellows for the new batch. So all of you will be seniors now, and you're gonna be leaders for some of the teams for the newcomers, the new fellows. So I hope that you share your knowledge so far, what you learned and the skills with the new group. So next week, we're gonna have a meeting with some of them, if they can attend the meeting, and see if anyone wants to share their so let's talk about the next meeting agenda. Any suggestions?
Hello, everyone.
Yes, please go ahead.
Hello, Dr. Nader. How are you? Hello, everyone.
Hello.
So I would like to inform you that our abstract about the non-pharmacological pain management is also accepted in the US ASP. Yeah.
Excellent.
And we will be presented in May on site on Ohio.
Oh, perfect. Excellent.
Yeah.
Excellent.
Thank you.
Congratulations. Thank you.
Okay.
I'll reach out to you as far as registration and the details. Thank you. That's good news.
Thank you.
And also, I just got an email from Barta Chaudhry, if I say the names are correct, but she is one of the fellows with us and she matched. So that's good. Congratulations to her. And I wish you all the best, guys. So let's go to the next meeting agenda. If there is any suggestion, please go ahead. So my suggestion is to introduce the new batch, and then maybe someone can talk about diabetes or something in general. I don't think we need to talk about telehealth. Maybe we'll talk about the future as far as new projects and their involvement. It's a big group, so we will talk about our past and then our future. Any suggestions? So I want to talk about a subject that might be of interest to you guys and maybe for the new batch as well, about the review, like literature review, just for a brief topic and how we can submit for further. In the past, we have had a couple of abstracts. We did literature review and all these have been accepted in different meetings or conferences, which is good. So the next step is to convert some of these into manuscript. So maybe someone will talk about how we write a manuscript in the future, like in next coming meetings, the steps of how we go over the introduction, the body, and the conclusion. We can go in details, but let's talk about just the brief abstract. It's going to be the same concept. So I'm going to share with you in the chat here. So I'm going to share the screen with you as far as what's in that app. Basically, here's just the steps of writing a literature review abstract so that we can send to, for example, conference or somewhere. So the idea is to identify what topic you want to talk about, read about it and see if it's important. So you go over the background as far as you collect some facts about that topic. So for instance, this article was just published a few days ago, weeks ago, depression and the impact of our relationship with exercise. I'll share the topic of the article with you in a bit. But they want to focus on the depression part, but the relationship with exercise. So they talk initially about the significance of depression and its impact. Then this is basically the importance of the topic. It's a leading cause for the health and so on. And then you mention what the study, what's your objective, or what's your aim. So what type of study you're gonna do? You want to do a systematic review, for instance. In this case, they did both meta-analysis as well. And then in the method part, you will have some certain areas where you want to include. So this method, for instance, you want to detail about the data sources that you looked at. Basically, you're going to search, for example, PubMed, Google Scholar, all these databases for the topic. And to do that, you need to use some keywords. So you certainly use certain keywords according to the title or the topic that you are searching. Sometimes you may go over like the limitation. So you're gonna get some of the data or the list of the articles that you got from this database. So you need to identify what the duration that you are looking for. Specifically, you want to mention the last date you accessed all this database, because people will look at it, let's say next year, and we'll look at your data. Is anything changed in the past year? If you did your literature review, let's say in 2021 or 2020. especially like if you are talking about COVID, for instance, in 2019 or 2020, the data we have is very minimal about what we know about COVID. In 21, we know a lot. Now in 22, we know much more. So after you identify the dates, I want to use, if you want to exclude or include what type of studies that you collect. Let's say you collected 200. Out of these 200, which one you want to include? So, and then you want to include only studies in English, or you want to exclude other part. And then you want to analyze the data. So how you obtain the data, how you verify the data. For example, this article talked about extraction was completed by how many reviewers or fellows in our case, and what we did about cross-check for errors and so forth. So you can do something like that. After you collected all this information, exclusion criteria, including criteria, then you want to look at the extracted information, or what you want to do with the data, like what you found. Let's say the number of patients in this included studies. So you want the numbers, and you want to span the years of these studies. Let's say the first study was done for 2 years. The second study was done for 4 years. So the total will be 6 years. So you want the total participant by the total year to calculate the person year that you will mention in your analysis, for example. And then you talk about the conclusion. What you think about the findings? Is it significant to the what you think is the title of your hypothesis? And then how can you put that in a way that can be generalized? And if your study is limited, you want to talk a little bit about limitation. In a paper, usually we finish with the discussion part or the conclusion part. In the conclusion part, you want to basically you want to summarize all in 1 or 2 sentences, maybe 3 sentences, but at least one graph identifying the most important, why this study is unique or new, why this study is important to the public, and what's the future, what are you going to do about this, like the future direction. So basically, the study here, I'm going to give you the link. It's this one here. Then how we can use similar study to modify it to a new study. For example, if we open this study, the title of the study is physical. Let me just share with you the study. So this is a study, basically association between physical activity and risk of depression. It's a system review and meta-analysis. And these are the steps that what we talked about. We can go over it, or you can do that at your time. But what I want to share with you is how we can change the title from what they have and the subject and the whole project or the idea into apply the same concept, but in older adults. So what they did is they mentioned only adults. In geriatric, we want to see if the same concept apply to all the others. So maybe we can change the title to physical activity and risk of depression in all the others in this is a systemic review, for instance. This too, but during COVID. So instead of looking at the literature from day one, like in the 80s or 50s, you can just say, I'm gonna review the literature in the past 2 years since the pandemic started and see what literature is saying about the physical activity and depression and COVID in all the others, something like that. So this is how you do this in a nutshell. I know some of you participated in some of these projects. Maybe I can just put one of you. Sarah, say it if you have a minute. Can you share your experience? Or maybe or someone who has a group.
Hello, Dr. Nader. Assalamu alaikum, everyone. For about the manuscript writing?
And not the manuscript itself, but how you did your project, like say the music and the abstract that we submitted to.
Well, actually, I was involved. I was a co-author in the music with Lina Lomari. With Lina Lauta, she was the team leader of this project.
Yeah.
I was the team leader for the topic on vitamin D.
Yeah, vitamin D. Yeah. So Lina can talk after you. Maybe you can just give us an idea about how you did that in your team, and Lina, maybe you can jump as well.
Yes, of course. First of all, I would like to thank you for your mentorship, and this has been a great year so far. And thank you everyone for your presentations today. They were very helpful and a good review about Parkinsonism and the heart diseases. So when we started about the project for healthy aging, so it was a very broad topic. So when we started gathering each other and teaming up together, so we noticed it has so many elements to discuss in one manuscript. So we decided to split up in multiple teams, but there were only 2 teams who were very active. My team, which was about vitamin D, and Lina's Lauta team about the music. So we've decided to be working on 2 teams, and each one will focus and gather the data. Someone collected it, and we will put all the data we collected, we review. We select our search criteria based on different databases, such as the PubMed database, Google Scholar database, and we set our age criteria. And we've decided our study will be the age, and if there's any kind of language restriction. So we wanted all our studies to be in the English language. And based on that, we started to collect the data in a table on Google Forms, on Google Sheets. And then the rest of the team, those who collected the data for the first time, added them. And then the rest of the team, we were split into teams of 5. Maybe the first 2 were involved in the data collection, and the rest of the team is involved in the double checking if the studies we selected in the Google Sheets meet our selection criteria, our study criteria. And then after that, we split up. Again, each one was assigned a role to write the manuscript, which was mainly the background, the method, the discussion part, and the conclusion. And as they were very good enough to be abstracts, they were just little abstracts. At that time, the AMA Research Challenge was being open and recruiting for and asking for to submit abstracts. And by that time, both teams are done with their abstracts. So submitted them to the American Medical Association Research Challenge, and both were accepted. As well, now we wanted to, and of course we include all the authors, in both teams as authors of the abstract. So we're a team of 10 people, and we split into 2 teams. Each one is of 5. And those who were active in their project, like the vitamin D, the first authors are the first 5 authors, and the rest are the second 5 authors in order. And this likewise in the case for the music. And then after we got accepted and submitted the abstracts and everything, we wanted to do it as a manuscript and involving other elements such as exercise, such as the proper sleep hygiene. And I think we're still we try to apply it and submit it in multiple journals, but it requires further working on it to be accepted. So I hope I answered the question though. Dr. Nader, you're muted.
Thank you so much, Dr. Sarah. This is great. I just want to see how you did it, and so that we can share it with this group and the next group. Hopefully, we can do something similar. Anyone else want to share their experience?
Thank you, Dr. Nader.
Thank you so much, Dr. Sarah, and congratulations for joining the residency. So if no other comments, do you have any other suggestion, ideas, or new projects that you want to share with us? If you do, please send me an email and we can work on creating a new project and work on getting some research project going. Thank you, everyone. And I'm going to send you email. I need you to make sure you have your full name for the certificate to be printed for you guys. And I want to you to let me know what's your direction as far as next year. Are you going to stay with us? We'll be happy to have you guys continue. If you are planning to not participate, if you go to another endeavor, if you are doing fellowship or other things in your life, we wish you all the best. Let us know so that we can divide the task in the future for other members who are active. Okay, go ahead, Dr. Mohammed Tijani.
Assalamu alaikum. Just a quick question. Is the door still going to be open? For example, if I'm in the middle of so many things during this summer to do, I might not be able to, continue regularly in the meetings, but hopefully maybe by the beginning of the fall semester, fall season, the door is still going to be open. I can rejoin again, or should I? Or
yeah.
how?
So for you are already here, so you don't have to go out and come back. So as the same goes for Salata, she has some obligation during the summer, let's say. So for everyone, I just need to know if you want to continue or not. Then the question would be: are you going to be active, or you will have some limitation? Let's say the summer you are teaching, or the summer you will be out of the country, or doing some master degree graduation or something, step 3 preparation. So you will not be available during so and so month. So if you let me know, I can just keep you on my list, or you will be active during other months, but during this period you will not be assigned task. Your experience, your knowledge is so important for us that you can share with the new coming generation. So we want some of you to be leaders for this. So if you let us know how you will be available, we can sign you as team leaders, let's say, and you can just follow these new fellows. And if they have questions, they can reach out to you during the time that you are available. And absolutely, if you are involved in any research project as much as you can, you will be able to publish. That's very good. If you are not active for whatever reason, we want you to get active after you are done with your, let's say, time when you are not free. And then take it from there. Maybe you can get into some of the projects and publish and finish some projects for your CV. So the idea is to ask you help us and help the new coming generation, but at the same time we want you to succeed in your other part of your life. the goal is to help you get into residency as soon as possible. But at the same time, we understand that you might have other things going on in your life, so we don't want to take too much of your time. It's just a balance. And at the same time, I don't want people to be listed, and then when we reach to them, they will be not available without letting us know. So it's disadvantage for both of us if someone not answering our emails, and we depend on them, let's say, on presentation. And if they don't let us know, they are not able to, it's gonna be just a waste of time for both the person and us. And I don't want that to happen. If that makes sense, if I don't make sense, don't bother.
Thank you so much, Dr. Nader. Thank you for your time. Thank you for all the energy and sacrifice you made for to help us, succeed. I really appreciate that.
Thank you. It's a teamwork, so I'm here just to help, and we work together. So all the work you are doing is greatly appreciated. So just attending the meetings is important, and doing the other types of whatever work efforts that you're doing is really appreciated. So I wish you all the best. The last point I want to make sure I put the research publication that we are like we have so far. So if any one of you wants to correct this, please let me know. I'm going to share the link again with you guys here and show the screen as well. So basically, I have to continue sharing the list, but I want you to look at that link maybe in a few minutes later during the day or next coming days, and correct the information as much as you can. So I'm gonna share this screen with you. Basically, I have listed all the abstracts, all the journals in that published our work, all the conferences that we worked on, and some of the videos if we did oral presentation, and your list of authors in that as well. So I think I did a long list of authors. So this is why it gave me this error. I need to correct this. But basically, make sure your name is correct, your other information are right. If I missed any abstract or any work that you did, let me know. And we'll take it from there. Any comments? Otherwise, before we finish the meeting. Again, thank you, everyone. Thank you for all the time you spent, the effort, and I wish you all the best. Thanks for the presenters today, and thank you for leading the team on the Zoom meeting. Have a wonderful day. I wish you all the best. See you and happy Ramadan. Ramadan. Assalamu alaikum.
Thank you so much.
Thank you.
Thank you so much.
Thank you so much,
Dr.
Nader.
Nader.
Assalamu
Thank you,
alaikum.
everyone.
Thank you.
Assalamu
alaikum. Thank you very much.
Thank you.
Thank you, everyone. Thank you, Dr. Nader. Assalamu alaikum.
Alaikum.